Gostaria de me apresentar primeiramente. Meu nome é Ana Maria, sou a diretora-geral da Merz Biolab e em nome da empresa gostaria de agradecer a presença de todos no nosso evento. É muito importante para a nossa empresa e para toda a classe médica na dermatologia tê-los aqui nesse momento que a gente tem uma mesa e convidados tão especiais. Queria chamar a doutora Denise Steiner para apresentar os médicos que participarão e os nossos convidados. Boa noite, obrigada.
Bom, boa tarde. Eu acho que nós vamos encerrar esse dia com chave de ouro. É uma excelente oportunidade que nós temos de discutir, né, as questões relacionadas à toxina botulínica com experts, né, do porte que nós sabemos que são o casal Carruthers. Então eu espero que vocês aproveitem. A ideia é, após a apresentação, que realmente a gente tenha uma discussão bastante rica de troca de ideias em todos os sentidos. Eu quero apresentar então aqui o Dr. Emmanuel França, que vai fazer parte também dessa coordenação, a doutora Doris Hexsel, que também vai acompanhar para discutir isso com a sua larga experiência, e a doutora Carruthers e o Dr. Alastair Carruthers, que farão então uma apresentação seguida dessa discussão.
Good evening. And Jean and I are grateful to be invited here to join you this evening. I just want to briefly answer this question. Why Jean and I? Well, we were the first people to publish, well, first of all to talk about and then to publish on the cosmetic use of botulinum toxin. We did the first dose-ranging study in the female glabella, the first and only dose-ranging study in males, the first dose-ranging study on the female forehead, first study on different dilutions, and so it goes on. And more recently we've been involved in all of the registration studies of botulinum toxins approved in North America. Firstly, Jean is going to talk about the early history of the cosmetic use of botulinum toxin A. And this is a very special presentation because she was right there at the beginning. As you probably know, approximately 50% of botulinum toxin is used for cosmetic purposes and 50% for therapeutic. And Jean's name is on the first paper in both those study areas. With that brief introduction, I'm going to hand over to Jean now.
Now, there may be people out there in the world who don't care about the cosmetic, and in fact, it's worse than that. They really think it's terribly trivial. They think it's useless, and people are vain, and they shouldn't do it. But if it hadn't been for the cosmetic use being so safe and so effective, why so many other specialties would not have looked into the miracle of botulinum toxin and used it on their patients. For example, headaches, for example, overactive bladder, for example, spasticity. I'm just starting the list. There are 35 different indications, but a lot of them are spin-offs from the success of the commercial, of the cosmetic use. And so you should all feel very proud because you've led the way. We have our usual disclosures of companies that we're currently working with in research and consulting. Now, we have to go to Europe. It's 1822. It's in the aftermath of the Napoleonic Wars. People are starving, people are dirty. And they're dirty when they're making their food. And so there are all these poor people who are going out and trying to have a normal life. And what they have is these sausages. These are really bad sausages, because after they eat these sausages, they get paralyzed and they die. Well, this is a bad way to spend your life, dying of sausage poisoning. But Justinus Kerner was the physician who figured it out, that there's something in those sausages. And if we could just find what it is, why, maybe we could use it therapeutically. So then we have to scroll forward a few years to Alan Scott and Ed Momini, who had a casual conversation at a meeting. And they said, you know, maybe we could use a drug. Maybe we could find a drug rather than surgery to treat miscellaneous strabismus. And so Alan went ahead and persevered with cobra venom, absolute alcohol, botulinum toxin, and also nerve gas, DHP. And those monkeys, all the monkeys except the ones treated with botulinum, either got terrible orbital cellulitis or they died. So it looked like botulinum was the winner. The monkeys were happy and safe. And this was the one that Alan then got approval to pursue in terms of the National Institutes of Health. And here's Alan. He's actually a Renaissance man, real genius. So he put the ideas all together, and I was fortunate enough to be able to work with him in 1982 in a fellowship in San Francisco. And now here's Alan in 1982 while I was doing my fellowship. And you can tell the clue in the picture that tells you it's 1982 is no gloves. In those days, people didn't use gloves so much, and that was, you can see he's using a really geriatric amplifier. But that is really what we had to do for the eye muscles, because unlike the muscles of the face, where motor end plates are plentiful, motor end plates, it's a feast, they're everywhere. With eye muscles, the motor end plate is actually way back here, about an inch back from where the muscle inserts onto the wall of the eye. So you injected the botulinum toxin using this amplifier with a hollow needle, and you can hear the motor end plate, hear the roar as the muscle recruits. Well, we don't have to do that in the face, but here we are doing it for a lady with a left lateral rectus palsy, and the needle goes right alongside her eye. We also used it for nystagmus, which is shaking eyes. And in many cases of nystagmus, you can actually improve their vision so much by treating all the horizontal rectus muscles that you can get them a driving license. But here's where the real start is, the cervical dystonia. I had been treating a number of patients with benign essential blepharospasm. And if you haven't seen it, these eyes are shut, they're spasmed shut. They can't cross the street, they can't earn a living. It's like they're visually blind, but they're not. It's just their lids won't open. And so this is one of my blepharospasm patients that also had cervical dystonia. It's a painful condition, and the necks and bodies are contorted, and it can affect many other muscle groups in their bodies. And so I took him along to the neurologists in Vancouver, and they hooked him up to this giant EMG machine that looked like an Assyrian door god. It was so big. And you can see, you can tell me the year. What year is it? 1982. You got it. Well done. No gloves. So it was in Vancouver as well. So here's one of the blepharospasm patients. And you can see how ingrained the spasm is because of all the density and etched nature of all the periocular wrinkling. And here she is after she's had some botulinum toxin injected. She's a new woman. And so this is one of these patients who actually got really angry at me. And she said, "You didn't inject me here." And I apologized to her and said, "I'm very sorry, I didn't think you were spasming there, or I would have injected you." And she said, "Oh, I know I'm not spasming there, but every time you treat me there, I get this beautiful, untroubled expression." Now here's where that marriage picture comes in, because I knew from Alastair that he had been having some trouble with his cosmetic dermatology approaches with the older fillers that were then available, trying to treat these lines. The surgical options hadn't yet been developed. And so I went home that night and said, "You know, one of my patients just told me this amazing observation, And I think I've got a solution for your frown patients. Let's just say that we had this really great discussion, and one of the people that was very important in our lives was our receptionist. And we actually treated our receptionist, who had the deepest frown lines. By 3 in the afternoon, she looked terrifying. And she had sat there seeing patients come in and out for 5 years. Always on time, always polite, always grateful. How often does that happen? But when you treat some people and they can see and live again, they're grateful. So we decided after we treated her, and I have her picture next. Here, you can see what a difference it made to her. You can see, so we put together our first series of 30 patients. Now, 30 patients I can see in a day now. It's just not a problem. And the same for you. But in those days, you want to inject what? Isn't that a poison? Are you going to kill me? There's just so much fear about the safety. So I realized the only thing I could do that would actually demonstrate to these people that it was quite safe was to get Alastair to treat me. So I'd say, what do you think? And they'd say, I want that. Because that was a lovely smooth brow and totally different to what I had before. I also had my before pictures around so they could see the difference. So we presented this paper at the American Society for Dermatologic Surgery meeting in 1991. And we were met with disbelief, incredulity, and silence, except for the immortal phrase, that's a crazy idea, and it's going to go nowhere. And that crazy idea is now the commonest form cosmetic procedure in the world. So it just shows that you have to work hard to take something and change its reputation. It was the most terrible poison in the world. And we had to work like Alan Scott had to do within ophthalmology. We had to work to show that it actually was great. So we're very grateful to you Brazilians because you have open minds and you are one of the countries that we were delighted to be invited to share what we had learned. And I want to say that I'm so pleased to see so many of you here and so interested in botulinum. So we were the first of a number of publications, and then we just really got into it because injecting botulinum toxin is an addiction. I mean, there's just no way you can get around it. And so, well, let's look at this lady. She's got rather sad, flat brows, almost masculine looking. And so we injected her here, 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 and here. So just in her medial area, we didn't inject laterally. But look at the nice lift she got. And you can see in the superimposition, black as before and red as after. And she's got a lovely lateral brow lift. And Alastair's going to go into this in more detail. So we got really fascinated because everybody always says, oh no, fillers are for the lower face. Botulinum is for the upper face. How many of you have heard that? Everyone? And so this we did a study with our friend Gary Monheit with 90 patients. And we had 30 randomized to just Botox. That was the neurotoxin we used. Juvederm, that was the filler, and then the combination. And I want to brag a little bit here about the research patients in Vancouver because we had 4 patients in our research group who said to us, can I be randomized to the both group? Because they understood. But if you look at the difference, here's before and here's at 24 weeks. In the neurotoxin group, there's a lovely lift, isn't there, to the lateral corner of the mouth, and a softening of some of the vertical lines, which Paco Perez calls the barcode. In just the Juvederm group, not so good really on the corner of the mouth, but a lovely fullness in the vermilion lip. But put the two together, She's got the downturn, which is now not turning down. Her vertical lip lines are much softened, and she has beautiful fullness in her vermilion lip. So this is another thing that we started saying, honestly, it's not monotherapy anymore. In most patients who are over about 22, you need more than just one thing, more than just neurotoxin. Now the other thing which we had no control over, but which was totally relevant to this whole thing, is the demographics. Because 1946 to 1964, about 80 million new people arrived in this world, the baby boomers. And so what happens when baby boomers reach somewhere around 38 to 40? They start noticing that they're looking a little bit careworn, a little bit in need of something to freshen them up. And that is exactly the moment that the old collagen and Botox came into the world. So it was a marriage made in heaven. Here was a treatment ready for those people. So if you look at all the websites, the aesthetic organization websites, cosmetic surgical procedures in 1997 to 2010 increased 71%. But the non-surgical procedures increased 500%. So the public are getting really smart and understanding I can get these things done without the downtime of surgery. And I'm speaking as a surgeon. The neurotoxins, if you single them out on their own, this is very surprising to me, but more men were interested in their neurotoxin than the women. How wonderful. And so that's a 4,000% increase. So the non-surgical procedures were primarily facial. The surgical procedures were primarily body procedures like abdominoplasty, breast lift, that sort of thing. So here's a structure actually in Selinente in Sicily when we were biking, but it's a structure that's lasted for years. And I think that cosmetic botulinum toxin is actually, it's really the first of many very successful procedures in non-surgical rejuvenation. And we think it's as good as penicillin, and maybe better. It's a generational drug. What is seen as a crazy idea is now accepted as mainstream, which is why we're all here today. So thank you very much. I'm going to turn this over now to Alastair for some practical fun with you. Thank you.
So in the next short while, I'm going to try and be practical and maybe to challenge some of you with your accepted practices. We'll see. But I'd just like to say before I begin, in my experience, I think that Onabot or Botox units are pretty close to Merz or Xiaoming, however you pronounce it, units. And mostly when I talk about units, because those are the two neurotoxins I've had most experience with, mostly I'll be talking about those units. And I'm afraid I still have a difficulty with converting Dysport units. Okay, so here are the first two laws of cosmetic botulinum toxin. The first, very simple. Where is the tip of the needle and how much effective botulinum toxin goes through it? There's nothing much else matters, really, is there? When you come right down to it, where is the tip of the needle? How much botulinum toxin goes through it? Second, when you're talking about reconstitution, and we've only been here a day and a half, and we've heard a lot about reconstitution. When you're talking about reconstitution, remember, dose is for the patient, dilution is for you. It's for your convenience. You happen to want to use this amount of fluid in the vial in order to give the concentration that you like to inject. But it's not got anything to do with the final result for the patient. It's purely dose that affects the result that the patient gets. So carrying on from that, what else don't I think makes much of a difference? Honestly, with botulinum toxin and with hand grenades, close is good enough. You don't have to get it exactly where you want. Of course, if you get it exactly where you want, you might get a higher dose there, and therefore you get a better result, which will last longer. But you don't have to worry about being too precise. And I particularly don't think that it makes much difference when you're talking about layers of muscle. We know that botulinum toxin will migrate through fascial sheets and so on. Ada Trindade, who is here, did the work on foaming and shaking, showing that what Alan had put into the early product insert was really irrelevant. And we, in North America, almost everybody uses benzyl alcohol in preserved saline, but I guess it's not available in Brazil? Oh, and you're so unkind to your patients because the botulinum toxin stings. Why would you do that to your patient? 0.9 milligrams of benzyl alcohol is a kindness. As Jean has just mentioned, this is the law, L-O-R-E. Upper face is botulinum toxin and fillers, lower face is fillers and botulinum toxin. And when we're talking about how we use it, these are some of the areas which we commonly use botulinum toxin. And especially in the upper face, we tend to include this group of things. But I would ask you to abandon thinking about areas and think of the whole upper face, so that when you're looking at an individual, you don't just say, I'm going to treat the frown, or I'm going to treat the crow's feet, or I'm going to give her a brow lift, him or her a brow lift. Instead, look at them, analyze the way they're using their face, and then map out what is the right dose for them in each area. One of the other things I've been hearing about since we came here a day and a half ago, it's been a pretty active time, is how many patients do you treat from a vial? If you were to ask Jean or I how many patients we treat from a vial, well, there is no answer. How many vials to the patient, Jean says. The individual needs so many units. It might be 48 or 62 or 21 or whatever. That's the dose that you should give, not a third of a vial or a quarter of a vial or a half a vial. Let's just ask you a question. Here is a young female with a few relatively minor lines. Now here we're talking about Jimin Botox units. Anyone give me a suggestion as to how much they'd put in this? Give me a total. Well, okay. This is what I would do, and in fact did do. You know, that there are a lot of young females who really don't need a high dose, and 5, 5, and 5 will give you a very nice result. Now, I've also, you might have noticed, put a little under the tail of the brow, and you can argue whether it should be 4 or 5, I don't know. This is a very common dose. Now, it's Botox light. You will need probably to redo her botulinum toxin every 2 to 3 months rather than every 3 to 4 months. But that's okay. This is very acceptable in an individual like this. So, and this is the result we got. And you can see from her platform here that she does indeed have a very nice eyebrow lift as a result of that. And of course, if she complains about this line up here, then you can put, and this would be a very common dose for me to use in the forehead. I'd probably inject a bit higher than it's noted here, but somewhere around about 10 units Botox or Xeomin units, and you get nice smoothing. What about an older female with significant lines? And this is the person who comes in and she says, my family are always saying to me, are you mad? And when they frown, they're really looking pretty mad. So I think in this kind of an individual, if you're not thinking somewhere up in the 30 to 40 unit range, you're not going to do a decent job. And the questions that you have to ask are, there we go. How far lateral are you going to inject? And are you going to treat the mid-pupillary line? So, for example, you might put something like 6 or 7 here, 10 units. Look at that great bunch of muscle there. You're not going to do any less than 10 units of Xeomin units or Botox units. And something up here. You have to inject somewhere out here, and we'll come back to that in just a second. Now, I should say, I'm talking here about a female brow, but I think that we really should be talking about brows that have more muscle, brows that have less muscle, and not be gender specific. I can tell you that in the Xeomin registration study, which was with 20 units, we had quite a few males who got a very good response with 20 units, which I wouldn't know, I will come on to, I don't believe in that. And then there are females like this who need much more. When Jean and I started injecting glabellas, we rapidly worked out that you had to inject this area. And people came back who could still frown, like this woman. And so I got out the EMG machine and we listened to where they were still able to contract muscle. And the answer is in the mid-pupillary line, right on the orbital rim. So, Jean and I injected half a dozen people right in the mid-pupillary line on the orbital rim, and Ada actually published on this, didn't you? How many cases of eyelid ptosis did you get? 2 out of 3 or 4. And I can tell you that we got, I think, 6 of 6 when we tried to do that. So that's why we started injecting up here, a centimeter above the orbital rim, in order to allow diffusion to come down. Remember our friend diffusion? Diffusion is your friend. Allow the neurotoxin to diffuse and get that muscle which is still working. I mean, look at the muscle that she's got here, the contraction. If you don't do that. But diffusion is not a respecter of gravity. It can go up, down, left, right, very happily. So there's absolutely no reason why you can't inject above the lateral canthus and allow it to diffuse medially rather than from above and allow it to diffuse down. Why is that? Okay, here's a 48-year-old woman, and she hated these lines on her forehead. It was her forehead that really bothered her when she came in. And I injected her as shown here. Can you all see that? Those units, once again, Xeomin or Botox units. So she comes back 2 weeks later. I hate it when this happens. Her eyes feel heavy. And you look at her and you say, maybe there's a little bit of something, but you know she's got eyebrow ptosis. Why does she have eyebrow ptosis? Anyone going to tell me? I'll tell you then. It's this little critter here. It's the injection in the mid-pupillary line that deactivated a significant amount of frontalis here and dropped her eyebrows. And that's why I have almost stopped injecting in this area, and now I'm much more likely to inject somewhere around here. Talk a little bit about filler. I think this is obvious. Okay, here's a question for you. If you have someone who comes in and he or she has deep lines in the glabella area, do you inject the filler the same day, or do you get them to come back? Same day? No? You get them to come back? You get them to come back. Why would you do that? Why deny them the pleasure? You know, if you put the filler in, it's going to look beautiful. And I don't know about you, but I tell my patients who come in with this kind of an issue, we're only going to have to put the filler in once. We put it in once, the first time I see you. After that, we maintain your Botox. You'll never need the filler again. And it's true. Anyway, this was our filler botulinum toxin study. Not these spectacular pictures. I mean, this is what people want. You take someone from that to that, they love you. And here is the results. Filler alone, the results really gone at 16 weeks, whereas the combination is still cooking along here at 32 weeks. Okay, let's talk a little bit about males. And I think it is impossible to overtreat the male glabella. And I tried. Here's our study. We had 4 groups, 20 males in each one, and they were injected in the glabella area with 20, 40, 60, or 80 units. And this is the result, just to cut to the chase. And you can see the yellow line is 20 units. Really didn't work. It didn't get as good a result, and it didn't last as long. You see how it's wearing off more rapidly. And we got really good separation of these groups out to about 20 weeks. 24 weeks, you've got individuals dropping out, so that it gets a little bit fuzzy. All botulinum toxin studies are most significant up to about 20 weeks. Interestingly, in our female dose ranging study, we got a sort of plateau effect above 20 units. Whereas with the males, the more we put in, the more they liked it, and the bigger the smiles. There's not any significant increase in adverse events in the high dosage unit. We actually put the 80 unit group in there thinking that we'd get some adverse events, and we'd explore the upper regions of what's safe. We didn't get anywhere close to it. What we tend to do is to use a high dose on males initially to get the effect, and then titrate it down until you get a dose and a frequency that they're comfortable with. Males like twice yearly botulinum toxin, whereas females are more likely to be comfortable with 3 or 4 times a year. And with males, you must go lateral to reduce frowning. So you see, this is the area that I'm in. I think putting at least 10 units and maybe more out here in males, it gives you a much better result. But with males, beware of the eyebrows and use diffusion to soften the forehead. Here is one of the early males with horizontal forehead lines that I treated, and I actually used these as before and afters to show a good result in the early days. Did I do him a favor? No, I didn't. This is a dreadful result. And the question I would ask you is, would you rather go and have a beer with this guy or with this guy? It's pretty clear, isn't it? This looks terrible. So that's what happens when you knock out frontalis in a male to try and soften these lines. Don't do it. So you see someone like this who comes in and they want this fixed. The last thing you would think of doing is injecting along here. What you do is to give his glabella a real good whacking, and then see him in 2 weeks. And often, diffusion, remember our friend diffusion, has done the job for you. And the brow is smooth, the line is gone. You may have to put a little bit up there, but surprisingly little. You might notice this little injection here, which helps to push up the northern end of this area of diffusion. Talking about diffusion, I hope you will agree with me that if we're injecting here above the orbital rim, typically we think we're injecting the frown, right? That's what I've been talking about for the past 15 minutes, so I hope you were awake. Whereas if you inject somewhere around about here at the junction of the temporal fusion line with the orbital rim, we talk about treating the brow depressors. And then you come down just a little bit and you're into crow's feet territory. We all agreed on that? Yeah? Does it matter? I really don't think it does. I think, remember, botulinum toxin and hand grenades, close is good enough. You can inject anywhere in this area and it'll do all three. So don't worry about it. What, of course, we do worry about is if you treat as I used to do, glabella and crow's feet, leaving this area here, then you'll get this very attractive wrinkling of the lateral eyebrow area. I mean, it's easy to resolve, but you don't want to create a problem like this. So what I tend to do now is to stitch around orbicularis oculi, starting from the medial eyebrow, going right the way around into the crow's feet area, about every 2 centimeters. The lower eyelid, for the right individual, injecting the lower eyelid produces a spectacular result. Doesn't it look like she's lost about 20 pounds here? And yet, I don't know if you can read these little red numbers. These photographs were taken 2 weeks apart. And all that's happened is 2 units of Xeomin Botox units under the mid-pupillary line. And the way to do that is to see how she's looking up. She's lying down, she's looking up so as to tense her lower eyelid, and my finger is also tensing her lower eyelid. So again, stitching around orbicularis oculi at roughly 2 centimeter intervals, avoiding bruising by injecting superficially, be cautious with infraocular orbicularis oculi. And I think that this is the area where we're most likely to produce the frozen look. And anything we do to reduce expressivity is a bad thing. Jean talked about the brow lift, and I'm going to go straight by that. No, I'm not. Look at this date. That's week 4, week 8, week 12, and week 16. Let's see if I can go back. Oh, yes. So this is serial photography of a woman who was injected with 30 units of botulinum toxin into the glabella area only. So the most lateral injection was mid-pupillary line. And these are just serial pictures, and I'll read out the what's going on down here. But you just watch what happens to her eyebrows. So that's baseline. Day 7, the lateral at week 4, week 8, week 12, and week 16 is just starting to come down. Isn't that remarkable? We didn't know anything about that when we did this study. But of course, if you are increasing tone in frontalis, which is what produces the effect that you just saw in that semi-video, then that's how also you get the Spock eyebrow.
This is one of the things that is just so vexing to all of us, because people say, well, which is the best one? Your new colleagues, new injecting colleagues want to know which one should I learn. So what we've done is to actually go over the whole literature of the comparison of the serotype A neurotoxins to try and tease out what might be science and what might be believable and truthful. You've seen our disclosures before. Now, there are a lot of worldwide available serotype A neurotoxins. I'm just going to confine my remarks to the Botox, Dysport, and Xeomin. But I know that you have Prosigna here. I know you have Botulift. And Puritox has had the phase 3 studies, but hasn't yet been approved in the United States. So could I trouble you to raise your hands? How many of you use Botox in your office? Could you put your hand up? Great. How many of you use Dysport? You can put the other arm up if you want. Okay. And how many of you use Xeomin? So I think it's actually really interesting. Another question, how many of you use more than one neurotoxin in your office? Show of hands. Okay. So that's really important because I think that it means that you have open minds and that you are discerning differences in the neurotoxins that are better for different areas in your patients' faces and bodies. When we look at how the neurotoxins are made, they're all botulinum toxin A. They're all from the Hall strain of Clostridium botulinum. There are some differences in how the product is actually, the dried product is put into the vial. And I think this is one of the things with Xeomin that we found in Canada that we had a little bit of a problem initially with Xeomin because it didn't seem as strong as we thought it should be. And then we understood that the manufacturing process of Xeomin actually, there is neurotoxin not just in the bottom of the vial, but all around the vial. So what you have to do is put your saline in and invert the vial several times in order to get it covered. And that's really made a huge difference. Has that been something that you've noticed in Brazil? Inverting the vial? Yes. Right. So there are lots of ways to compare the differences with botulinum toxin. And so let's look at some of those and see if they can be helpful to us. I feel humbled to be talking about diffusion and spread of effect here with both Ada and Doris right next door to me here. So if I make a mistake, I know they'll fix me. So there are various studies comparing the diffusion or spread, and there seems to be a similarity, an equivalence with the Botox spread and Xeomin spread. And the Dysport seems, in some studies anyway, to spread a little bit more. The stability and storage. We've actually, I cry when I've realized how many vials I'd thrown out after I'd had them open only 4 hours. We found a vial in the back of a fridge that we'd had for a month. And of course we injected it into Alastair. And it was actually very successful, it worked fine. So the nice thing about the incobotulinum is that the unopened vials can be stored at room temperature, as can the ANA and the ABO. But once they've been opened, they need to be refrigerated. So I think that the immunogenicity is an important point. And it's the foreign protein. So many of us remember the botulinum toxin that we had before 1997. And there was a huge incidence of cervical dystonia getting patients with big doses, getting IgG neutralizing antibodies. And it was as high as 50% in some series. And then Allergan took out 80% of the protein load, and it just went away as a problem. And so when you look at Xeomin, which is like the neurotoxin without the overcoat, without the complexing proteins, then at least theoretically there should be a zero incidence of a secondary non-response. And so is this true? So we looked at quite a few studies with Marcus Naumann on a botulinum toxin, 16 studies, and we looked at 2,200 patients out of those studies with varying doses from small to large. And total average of 0.49% seroconverted. So that's interesting. And it was higher numbers in the higher dose patients, cervical dystonia and hyperhidrosis and spasticity, and less in the glabella. So then what about with incobotulinum? What about with Siamin? And so looking at the package insert, across pivotal trials in cervical dystonia, blepharospasm, and post-stroke spasticity, I was 1.1%. Well, you'd think it would be 0. But here's the rub. You can't really believe that, 1.1%, because the subjects were not botulinum toxin naive. And if you had eyes that spasm shut and the torsion and contortion that the dystonias give you, you would be treated as well. So I think that these numbers are spurious. And if you look at the US trials, 3.4%. But again, none of these people are botulinum toxin naive. Why do you have the overcoat? And the reason you have it is not really known. It might be to protect the 150 kilodalton active portion. It might be to shield the active portion from the soil when it's in the ground, waiting to infect your war wound. It might be that it's there to protect the 150 kilodaltons from the stomach acids. We just don't know. But we assume it gives stability. Abobotulinum toxin is a slightly different neurotoxin because it's quite heterogeneous. This is a really old reference because this is the only reference we could find showing what it's like in the bulk toxin. And we think that this actually may explain some of its diffusion characteristics. Now, this is the theory that you inject the botulinum toxin complex. So, in this talk, abo and onabotulinum, it dissociates. So now it's just the same as Siamin, and then it binds to the receptor on the neuron or on the muscle. And so this is some research that was done from a scientist, Dr. Hexsel from Merz. And it shows that when at a more acid pH, the complex that they were studying hugs the active 150 kilodaltons, but as you make it more alkaline, it splits apart. And how long does that take? Well, they're looking at somewhere between 1 and 15 minutes. And so that's really an interesting study. We don't know if we need to see some more studies about this. We don't know if different neurotoxins have different rates of dissociation of their complex. And so I think it's a really interesting point. Now let's get into the therapeutics. All botulinum toxins work. This is why you're here. So many times you've done a study where they give you all these photographs and they say, will you please sort them out into before and after? And you can't, because there's just not enough difference between the before and the after to see a difference. And I can show you many pictures like that from studies. But botulinum toxin works, so you compare it in a study to placebo, it works. And that's what's so exciting about it. It works for everybody. And it's very true as well for incobotulinum toxin against placebo, and a lot of studies from all over the world are confirming that. So here is the problem we have. Is one neurotoxin better than another, or worse than another, or are they all the same? And what we need is studies that are actually designed the same way. The clinical trials have exactly the same inclusion and exclusion criteria, identical age and ethnicity of the subjects enrolled, identical quantities of severity, and using the same measuring scales. You just wouldn't believe when you look at the literature. It's a 4-point scale, it's a 5-point scale. There's no men, there's no individuals with any tone in their skin. There's no decent photographs. There's no patient-reported outcomes. So it's very hard if you don't have the same ruler to measure the equivalence of the effect of these trials. Now, Gerhard Sattler and Valerie Callender tried to do this in 2010, and they actually showed that incobotulinum was non-inferior to onabotulinum in the glabella at 24 weeks, which is fantastic, which is great. So the important trial differences in the previously performed trials are part of the problem, but a new problem has come along, and that is that the FDA has mandated a new definition of responders. What most people have had in the past is a 1-point improvement, which is a positive response. But now the FDA want there to be a 2-point improvement, and they want the subject and the investigator to see the same response, or they can't count that as a positive response. So what you see in this endpoint is that you're not going to know how many people had a 1-point response and how long that lasted. And that's actually a rather happy thing, a 1-point response. Patients are often very happy with that for quite a long time. And so I think that it's going to make it a lot more stringent. It'll certainly take out the placebo effect. It'll take out people seeing an effect in the placebo group. But it's going to cut it right down in terms of percentage of improvement, because the subjects are not allowed, and the investigator are not allowed to look at the previous photographs. So we tried doing a study, a phase 3 study for incobotulinum versus placebo in the glabella. And Hanke and Narens did a similar study, in fact, an exactly similar study. And so we had exactly the same inclusion and exclusion criteria, dosage, randomization, study evaluations, and we were looking at a 1-point improvement. And we got this and statistics, and we got this wonderful improvement of 93% for the investigator and 86.5% for the subjects, which I think is amazing. But when you look at the new FDA way of counting things, you're probably going to see something like 20%. So what we were trying to do is to show that you can actually, in different centers in different countries, perform absolutely identical studies in large numbers of patients to try and sort this problem out. And you can see this is at 30 days, and you can see it's about 80% for onabotulinum. It's exactly the same for Dysport, and in fact, it's exactly the same for incobotulinum. So I think that these are studies that have not been made exactly the same, but they do show that there's tremendous similarity between the effects of all the neurotoxins. And this is what we were talking about, the longer partial effect, which a lot of our patients actually like because they don't like that frozen look. So apples and oranges are what we've got in the literature right now. And I think that we're going to see that it's not going to bother a lot of people. They're going to make their mind up anyway, be for other reasons why they like a particular neurotoxin or a set of neurotoxins. But I think the whole point about this is so exciting to see that we've come this far. We're really in kindergarten with these neurotoxins. And we need to do some more sophisticated studies to show that it's going to be better for one thing or another. In the therapeutic literature, we certainly show non-inferiority with inco and onabotulinum. Now, a couple of studies, 20 units versus 30 units. 20 units is the standard registration dose in those two neurotoxins. And Morris Carpy and co-authors used 20 units of Botox and found it was equivalent to 30 units of incobotulinum toxin. And Prager and Rappel and co-workers did the opposite study, using 20 units of incobotulinum versus 30 units of Botox. And they found exactly the same results on both sides. So that was interesting. And I'm just coming back to that dose-ranging study. We found that in the female dose-ranging study, there really wasn't much difference between 20, 30 units, and that would actually confirm Morris Carby and Prager as well. I just wanted to come back to dose. The most important thing you should be thinking of, besides where is the tip of your needle, is what dose are you giving? And in my office, we actually charge by the units. We don't charge by the region, because then you can be more exact with what you're doing. But the larger the dose you are able to administer, the longer it will last. 20 units into the brow will last probably, 2.5 to 3 months. 40 units in the brow will last 4 months to 6 months. So it makes a huge difference. So we've sort of touched on all these different things. We don't know what the comparable doses are, except from these studies. And it would seem that with the Botox and with the Xeomin, that there is excellent comparability in the therapeutic group and most likely also in the cosmetic group. We just need to have some more studies and have people really think about dosage when they're injecting their patients rather than region. Now, here's a little thing that we've had happen. We've had about 10 disasters that we've been phoned about or emailed about, where the physician has had a number of different products on the tray, and each product actually has exactly the same syringe, so the local anesthetic, the neurotoxin, and the hyaluronidase, all in the same syringe. So now the physician's in a hurry. They're looking at the tray, and which one is which? They're not labeled. And so it's a disaster. We've had these people thinking that they're injecting local anesthetic in order to do filler injections, and now the whole face, 35 units of neurotoxin, paralyzed one side of the face, and that person is getting married in 2 weeks. So it's a disaster, and it's a preventable disaster. We prefer using the syringes that are hubless, because you get all the neurotoxin out of the vial that way, instead of losing some in the hub of the needle. So pick one that you're using. If you're having, quite a few of you are using more than one neurotoxin in your office, pick a syringe. It doesn't have to be this one, but pick a different syringe for each neurotoxin. I think they're both fantastic syringes. So the 3 botulinum toxin A neurotoxins available on the North American market are indeed different from each other. And these differences are important, but they're also remarkably similar. And we suggest for most offices where, if you're running like we are in our office, you want to keep things simple so that you don't have any trip-ups. Getting to know one neurotoxin and using it most of the time so you really understand how to use it. Thank you very much for your attention.
Então, a primeira pergunta: qual a explicação para a ocorrência de pitose palpebral pós-aplicação de toxina botulínica nos pontos clássicos? Qual a conduta para tratar essa complicação?
I think that you saw nicely that Alastair showed that if you inject in the mid-pupillary line, within a centimeter of the bony margin, you can feel on yourself right now. Just take your finger and feel your notch, your supraorbital notch. And you want to stay well away from that because it's like a highway into the orbit. So that's why Alastair is suggesting injecting here and staying away from this, because you get this area on each side of the notch just simply by diffusion. Now the treatment is actually more botulinum, if you can get the patient to accept it, or iopidine. Iopidine is a glaucoma medication. We have many bottles of it in the office just in case. We hardly have to use it, but the ptosis is gone in about 4 minutes, and they are totally fine. It takes somewhere between 2 weeks and 6 weeks for it to settle down. If they have the confidence in you, injecting 1 unit of botulinum toxin right here, just above the lashes and below the fold, that will lift their eyelid as well.
Can I ask, do you know how to tell the difference between primary eyelid ptosis and eyelid ptosis secondary to brow ptosis? It's just one of those useful things to know, so you know what the problem is and therefore how to treat it. If you have primary eyelid ptosis, the eyebrow will be up because the eyebrow is trying to lift the eyelid. Whereas if it's primary eyebrow ptosis, the eyebrow will be down and the eyelid will be down. There you go, another tip.
A outra pergunta é uma apresentação de um caso de uma paciente feminina de 47 anos, primeira aplicação de toxina botulínica, e foram aplicadas 23 unidades de botox na glabela com paralisação completa em 15 dias. Porém, a partir disso, ela apresentou episódios de contração involuntária dos corrugadores e próximo, com duração de 3 minutos por vários dias. Após um mês da aplicação, já houve perda completa da resposta do botox. Gostaria de saber se já tiveram um caso semelhante e qual a opinião sobre essa situação.
I've seen that occasionally. It's really because the patient's underdosed. And the first patient I came across like this was an Olympic rower. And I treated her with 25 units. And she came back in a couple of weeks and she said, didn't work. And I then woke up. She's an Olympic rower. What they do is they screw their face up and they're rowing and pulling as hard as they possibly can. So they have big muscles up here, just like a man. I had totally underdosed her. So I think the fasciculation that the questioner mentions is part of being underdosed. I think just using a larger dose, like 30 or 35 units, would actually be very helpful.
Yeah, I agree. Fasciculation is a sign of an undertreated muscle or a recovering muscle. So you'll see it now and again in the infrontalis particularly, but elsewhere. It's not very common, but it's because you've underdosed or because it's wearing off. Give them the juice.
Doris, você quer comentar alguma coisa?
Eu realmente nunca tive um caso semelhante, mas eu acho que se a gente for um pouco para o lado da terapêutica e pensar nos pacientes com paralisia facial, eu já tive a oportunidade de tratar alguns casos, a gente percebe que eles têm realmente esses espasmos. Então é possível que talvez uma paralisação de um grupo muscular possa gerar esses movimentos involuntários transitoriamente e reverter da mesma forma que ocorre nos pacientes com paralisia facial. Essa é a minha hipótese, uma vez que eu experiência nesse assunto eu não tenho, mas eu acho que seria da gente pensar que os pacientes com paralisia facial também apresentam.
Uma pergunta em geral importante, a questão do zinco, né, da influência do zinco no efeito prolongado da toxina. Então, se os estudos mostram que seria só naquele momento da aplicação, e se eles têm alguma experiência com o uso talvez continuado, se seria válido ou não do zinco para a gente ter uma duração maior no efeito da toxina.
I honestly have not used zinc. I have been underimpressed with the science behind the studies I've seen. The studies I've seen have been done by people who have commercial interests, so I'm biased in the other way automatically. It doesn't make any sense that the neurotoxin has the zinc atom right in there. In order for it to work at all, the zinc atom has to be in there. Why should adding more zinc have any effect? I don't know of any science behind it. But Doris, though?
Eu concordo plenamente com o que o Dr. Alastair comentou. Eu acho que eu gostaria de destacar um dos pontos importantes, porque houveram muitos pontos importantes durante essa apresentação, mas um dos pontos que eu considerei assim, mais importante é uma mensagem muito clara que eles deram, assim, é a mensagem número 1, que o que importa no resultado é realmente a quantidade de unidades que você coloca e aonde você coloca. Então, eu acho que isso é o que a gente vai garantir o efeito para os pacientes, injetando realmente a quantidade de toxina que o paciente precisa. Então, acho que nós não precisamos utilizar zinco ou outros artifícios, digamos assim, para garantir os efeitos. Eu acho que o que nós podemos garantir o efeito para o paciente é realmente aquilo que o Dr. Alastair falava, dose é para o paciente. Então, se você quer dar resultado para o paciente, você tem que usar uma dose adequada, um número adequado de unidades para cada área que você injeta.
I think that you're absolutely on. People are looking, see, we always say men will only come in every 6 months, right? And women will come in every 3-4 months. Now women are saying, couldn't it last a bit longer? And ask yourself, what are you doing to your female patients? You could easily give them longer time just by giving them a bigger dose. And that's what I try to do, because life is so busy in the office anyway that seeing everyone every 6 months is just a pleasure.
Paciente feminina, 57 anos, terceira aplicação de toxina. Primeira e segunda, botox. Terceira, dispor. Revisão no 14º dia, perfeito. 25º dia após a aplicação de dispor, apresentou desvio da comissura da boca e paralisia à esquerda, semelhante à paralisia facial. Efeito adverso, migração, paralisia facial associada, o que pode ter acontecido?
There are a number of questions, of course. If she, the implication of facial paralysis is that you have some weakness below the level of the zygoma, something's going on down here. So then was the individual injected lower down? You can certainly, if you're injecting the crow's feet, if you happen to come around a little bit too far, you can get zygomaticus major. But I had someone in the old days when I did, when I was injecting lips, I would use nerve blocks. And she described a weakness of her lower face apparent when the nerve blocks wore off, when she was no longer in the office. And she was really relaxed about the whole thing because her husband had had a really bad Bell's palsy a few years previously. And I was absolutely panic-stricken. But what had happened was, in retrospect, that she had a coincidental Bell's palsy. And we mustn't forget that Bell's palsy is common, so that it is not unlikely that you will inject someone and at some time in that 2-3 week period where you're likely to see adverse events, they will develop Bell's palsy. So that always has to be number 1 on your list. But then think about all the other things, sure.
Eu quero fazer um comentário. Eu tive uma paciente também que veio, que eu atendi. Não fiz aplicação de toxina, foi só preenchimento, e a paciente foi numa sexta-feira, na segunda-feira ela mandou uma foto com o rosto torto. Pode ter acontecido um hematoma, alguma coisa, me manda a foto, ela não estava, tinha viajado. Aí, como resultado, ela teve uma paralisia de Bell, e num primeiro momento eu até achei que fosse um hematoma do preenchimento. Mas à medida que eu pedi que ela me mandasse fotos com movimento, eu percebi que ela estava realmente tendo uma paralisia facial. E aí ela procurou um neurologista e realmente confirmou a paralisia de Bell. Então, como o Dr. Carruthers disse, isso é um tipo de paralisia relativamente frequente e a gente tem que conhecer também para poder fazer um diagnóstico corretamente e encaminhar o paciente para o tratamento específico.
If you have a patient who has what looks like some kind of a complication which might be related to the botulinum toxin, and you're thinking of sending them to another physician for an their impression, for example, an ophthalmologist, ENT, neurology, be sure to find someone who knows what botulinum toxin is all about. Otherwise, you get the most ignorant response, and it does nothing but upset everybody. And it takes a long time for those people to come down. Meanwhile, they've been worried they've got a brain tumor, they're having unnecessary investigations. Whereas if someone who knows botulinum toxin, they'll say, don't worry about it, it's fine, carry on.
Uma pergunta, se já usaram toxina botulínica para o tratamento das contrações involuntárias que ocorrem na doença de Parkinson e qual a marcação?
The people with Parkinson's, is the person who asked the question, can you clarify, are you talking about eyelids or are you talking about more peripheral muscles?
Ela diz contrações involuntárias faciais do masseter, que ocorrem no Parkinson.
Sometimes people with Parkinson's get a condition called an apraxia. So if you say to them, open your eyes, they can't do it. But if you say, follow my finger, they can look up. And sometimes that confounds things with Parkinson's. But there shouldn't be a problem treating masseter and mid and lower face. But the lids can be a problem with Parkinson's because of the apraxia.
É uma pergunta bastante importante, embora tenha sido comentado. Qual é a diluição que vocês preferem e a conversão de doses que vocês usam entre as toxinas de 100 unidades e de 500 unidades?
We did a dilution study where we used, this was with Botox actually, and we used 1, 3, 5, or 10 ml per 100 unit vial. So that 10 units would be anywhere in between 0.1 to 1 ml. And we treated individuals, these were females in the glabella area with 30 units. And we were unable to demonstrate any difference between the 4 groups, except for the 10 ml per vial group had some relatively short-term fluid problems, swelling of the upper eyelid, sort of thing you might expect when they've been injected with 3 ml. And I think 1 or 2 of them also seemed to have a little bit more diffusion, but it was very minimal and it was not statistically significant. So that's why I say you can use whatever concentration you like. If you get out to 20 ml per vial, Jim Fulton tried that, it's just impractical. My suggestion that using Xeomin or Botox somewhere in between 1 and 5 ml per vial is best. Why use more than you need to? We have those beautiful diabetic syringes, the BD2 ultrafine syringes. if you use 1 ml per 100 ml, 1 ml per 100 units, they're actually labeled in units. Why would you complicate life by putting more in and giving bumps to your patient that take longer than it takes for them to get out into the waiting room? With regards to conversion, hey, we've got real experts here who know all about conversion for Dysport, Botox, and I just hate that discussion. So let's talk about something else.
Vocês querem comentar as doses, como vocês fazem?
Eu acho que é muito importante esse estudo que o Dr. Carruthers comenta, que eles usaram volumes bastante altos, e isso reforça um quesito que eu entendo até como segurança para o médico, que você continue usando aquela diluição que você tem experiência. Eu acho que isso é importante, que você não troque para a diluição que outros profissionais usam. Tenha a sua diluição, conheça a sua toxina, usa com segurança, e realmente não tem por que você alterar o volume, uma vez que realmente tu pode dobrar, triplicar o volume o que vai importar realmente no resultado é a dose que você vai utilizar. Com relação à equivalência, hoje está mais ou menos, digamos, aceito internacionalmente, em função de vários estudos que já tem na literatura, que essa conversão de 1 para 2,5, ela torna os produtos 1 para 2, entre 1 para 2 e 1 para 2,5 a gente pode ter realmente resultados comparáveis.
Quer falar, Emmanuel?
Em relação à diluição, o que eu percebo é você diluir, por exemplo, para 1 ml ou para 2 ml. O importante é você ter uma segurança naquela diluição, porque quando você dilui com 1 ml só, você tem que ser muito preciso também para não colocar uma dose maior do que você gostaria. Então, o que eu vejo na prática é isso, quem está acostumado com 2, quando passa para 1 ml, muitas vezes coloca mais do que deveria, né?
Eu posso só acrescentar eu tenho assim pouca experiência com o Xiaomi, mas realmente a gente realizou um estudo e a minha impressão realmente é que ele é equipotente ao Botox. Eu também tenho essa impressão com a pouca experiência que eu tenho desse processo.
Tem aqui mais 2 perguntas. Quais são os seus cuidados na diluição do Xiaomi? E doses maiores para hiperidrose também fariam o efeito durar mais tempo?
Can I answer the second part first?
The second part,
Yeah. The answer is yes.
Yes.
Yeah. Higher doses do make it last longer. Great. I'm glad you asked that question. What was the first part?
Cuidados com a diluição do Xiaomi.
So, just remember the manufacturing process. If you look at some of the neurotoxin vials, it's just that little white powder at the very bottom of the vial. But with the CMN vial, it's all over the inside of the vial. So you have to do a little bit different technique. Put the saline, whatever your choice is, into the vial and invert it. Because the reason you have to do the inversion is to persuade all that toxin that's hanging onto the wall to come off down into the bottom, so you can actually take it nicely out of the vial.
Jean and I have done literally thousands of 20-unit injections into the glabella area, and it works just fine. Just works fine. It's not left.
Nós temos já com o horário encerrado, né? Então temos que terminar essa sessão. Eu acho que nós tivemos um dia bem produtivo. Eu estou muito feliz com o acontecimento desse evento e a gente poder ter aqui essas pessoas que são verdadeiros cientistas, né, nessa questão principalmente da toxina botulínica. E encerro agradecendo a todos e esperando vocês amanhã às 8h30 novamente. Tá? Obrigada.